So patients who reach second-line status in the setting of HCC are used to be few and far between, but increasingly as our ability to treat patients effectively in first line with therapies that maintain good liver function and good functional status are improving. We are seeing a fairly significantly increased number of patients who get the second-line therapy. This is, again, good news for patients who have advanced HCC because they're hopefully able to benefit from potentially life-extending therapies. By the time a patient gets to second line, clearly we have to make a reassessment of liver function, ensure that these patients continue to have an adequate liver function that would allow them to benefit from treatment without jeopardizing their overall life expectancy due to worsening of liver disease. So we want to see a patient with a reasonable bilirubin. We want to see a patient whose MELD score, which I referred to before, has not shot up very high, certainly not above 15 or 20 would be potentially problematic in some of those patients. We want to see a patient who doesn't have massive uncontrolled ascites or bleeding or major complications of liver disease. We definitely want to see a patient who's got some reasonable preservation of functional status as reflected by the ECOG performance status. And so when we think about second-line therapy, there is now a long list of therapies that are approved and endorsed by NCCN. These include individual immuno-oncology drugs such as pembrolizumab and nivolumab, as well as tyrosine kinase inhibitors, including regorafenib, cabozantinib, and ramucirumab. And all of these are treatments that could, in the appropriate patient, be good options for a specific clinical situation. It is generally acceptable, though by no means proven without any shadow of a doubt by evidence, that if someone has received immuno-oncological therapy in first line, this is not necessarily something that's currently clearly approved by any FDA indication, but assuming that a patient received immuno-oncology in first line, the precedent for initiating another IO drug in second line certainly does not exist in HCC and probably rarely exists in any other cancers that I'm aware of. Therefore, if a patient has received that therapy, or if they have received a tyrosine kinase inhibitor in first line, which would be, as I mentioned before, sorafenib or lenvatinib, a reasonable second-line agent could be one of the tyrosine kinase inhibitors that I mentioned, cabozantinib and regorafenib, monoclonal antibodies such as ramucirumab, which addresses vascular pathways. But if a patient has received a tyrosine kinase inhibitor in first line, immuno-oncology drugs such as pembrolizumab and nivolumab would potentially be appropriate. So that is one fork in the road where one could use clinical judgment to decide on which choice of treatment to offer the patient. Another important consideration is how well a patient has tolerated first-line therapy, especially if it's a TKI. If a patient did well with sorafenib for a long time, many months without experiencing major adverse events, consideration of another TKI such as regorafenib or cabozantinib in second line is certainly very reasonable. If they have not and potentially are struggling with side effects of TKIs, which a lot of them are actually a class effect, right? So fatigue, for example, would be something that across the board TKIs would be potentially a cause of, then perhaps shifting to an IO option is reasonable. So while there is a fair amount of common sense and just clinical judgment that needs to be exercised, there are some general rules of the road that the clinician could benefit from when thinking about initiating second-line therapy.